Welcome, and thank you for joining the California Asthma Control Strategies webinar series. In this first webinar, we'll discuss the burden of asthma and how we use asthma surveillance data in our programs. My name is Ashley Kissinger, and I lead the state asthma program at the California Department of Public Health.
And I'm Jacqueline Wong. I'm the epidemiologist with California Breathing.
Go to the next slide. Perfect. First, we would like to introduce the state asthma program, California Breathing. We focus on asthma surveillance and developing interventions that improve asthma self-management education in environmental conditions that cause or exacerbate asthma in the most vulnerable populations in California. California Breathing developed this three-part webinar series to review asthma control strategies in California. And over the next 3 months, we will discuss the burden of asthma and how we use asthma surveillance data in our programs, which is today's webinar. In October, we'll review the Asthma Management Academy, a statewide asthma self-management education program for community health workers and its evaluation. And lastly, in November, we'll present an assessment of asthma control strategies currently provided by California clinical and non-clinical stakeholders.
Thank you, everyone, for joining us on today's webinar about the burden of asthma in California. The objectives of today's webinar are, one, to describe the burden of asthma across the state, and we'll do this by looking at a variety of asthma indicators, costs due to asthma, as well as asthma inequities. Second, we'll describe how California Breathing uses asthma surveillance data to guide program activities. Third, we'll answer any questions that arise, so please feel free to enter those into the chat as they come up. And fourth, this is very important to us. We'd like to gather information from you, the participants, on your use of asthma surveillance data. We're interested in whether you find the data to be accessible and whether any additional asthma indicators would be useful for this work, for your work. And this information is really helpful for us to improve our program. So please stick around so we can get your feedback at the end. This is an overview of California Breathing's asthma surveillance system, including the main data sources that we use and the asthma indicators that we generate. Asthma data are collected from several sources, including the California Health Interview Survey, or CHIS, which is the nation's largest state health survey. CHIS interviews approximately 20,000 California households per year, and their survey includes questions regarding asthma prevalence, work and school days missed due to asthma, as well as asthma management strategies or practices. We receive data from the Office of Statewide Planning and Development, and from them we get information on asthma emergency department visits, as well as hospital discharges, and these come from all state licensed hospitals. We also receive data from the California Department of Health Vital Records, and we receive death certificate data so we can learn about asthma deaths. And all of the asthma indicators that I just mentioned are factored into estimating the costs due to asthma in California. So we'll start off by discussing asthma prevalence, which is the percentage of people who have asthma. And in asthma, we talk about two types of prevalence: lifetime asthma prevalence and current asthma prevalence. Lifetime prevalence describes the percentage of people who have been diagnosed with asthma by a healthcare provider at some point during their lives. And current prevalence describes the percentage of people who have been diagnosed with asthma and also report that they still have asthma or that they've had asthma symptoms within the previous 12 months. This slide shows lifetime and current asthma prevalence in California and the United States over time, with prevalence on the vertical axis and year on the horizontal axis. And lifetime prevalence is shown in blue, and current prevalence is shown in orange. And within each color, California data are represented by the solid lines, and US data are represented by the dashed lines. In 2019, 15% of Californians, or 6.2 million Californians, reported having been diagnosed with asthma at some point during their lives. And 8.6%, or 3.5 million Californians, reported that they still had asthma. Lifetime asthma prevalence in California has increased roughly 25% over the past 2 decades. Lifetime asthma prevalence in the US, this dashed blue line, has generally been lower than that in California, but has also increased during this time period. Current asthma prevalence has been similar in California and the US over the past 2 decades and has remained relatively steady. This graph shows asthma prevalence by age, with prevalence again on the vertical axis and 4 age groups on the horizontal axis. And in this graph and in subsequent graphs, lifetime asthma is represented by the blue bars, and current asthma is represented by the orange bars. And it's important to remember that these data come from surveys, so there's some margin of error. In other words, the estimate that we get from the survey data likely is not the true prevalence in the population. And at the top of each bar, we have these gray lines, which are the 95% confidence intervals. And the longer the line, or the wider the interval, the less certain we are that our estimate is correct. And also, when we compare estimates between multiple groups, we can look at the 95% confidence intervals, and if they overlap, that tells us that the estimates are not statistically different. And so to illustrate that point, if we look at lifetime asthma in just 2 groups, children 5 to 17 versus adults 65 and older, we can see if we look at just the estimate, it looks higher in the children. But if we look at the 95% confidence intervals, we can see that they overlap. So in other words, if you extend out the ends of the confidence interval for the children 5 to 17, you can see that this interval includes part of the confidence interval for the older age group. So because of that, we would say that statistically that these estimates are not different from one another. So going back to the full graph, we can see that prevalence, both lifetime and current prevalence, are lowest in the youngest age group. And it's important to keep in mind that when trying to diagnose asthma in very young children, it's difficult to measure lung function in this age group. And also there are several childhood conditions that present with asthma-like symptoms. So diagnosis in this young age group is very difficult. For lifetime asthma, again, looking at the blue bars, in children 5 to 17, school-age children, it's similar to that of adults. And then also current asthma is in school-age children 5 to 17 years is also similar to that of adults. When examining asthma prevalence broken down by both gender and age, we see that in children 0 to 17 years, when we look at males, which are shown on the left, and females shown on the right, and we compare lifetime asthma prevalence, so again, these blue bars, we see that there's no difference between the males and the females for lifetime asthma prevalence, and there's no difference between males and females for current asthma prevalence. However, when we look at adults 18 and over, when we compare lifetime asthma prevalence, we see that it's higher in females compared to males. And also current asthma prevalence is higher in females compared to males. This graph shows asthma prevalence by race ethnicity. So again, on the vertical axis, we have prevalence, and then on the horizontal axis, we have different racial ethnic groups. And the estimates for lifetime and current asthma prevalence are highest among American Indian Alaskan Natives of all the racial ethnic groups we're able to analyze. However, there are very large confidence intervals for these estimates because of the small number of survey responses, such that we actually would say that the estimates for this group are not statistically different from those of several other groups, including Californians that identify as Black, Native Hawaiian Pacific Islander, and multi-race. Of note, current asthma prevalence, so this orange bar, for Black Californians is higher than that for white Californians. And both lifetime asthma and current asthma prevalence are higher for Black Californians compared to Hispanic Latino Californians and Asian Californians. In general, Hispanic and Asian Californians tend to have the lowest asthma prevalence. But lumping all Hispanic Latinos into a single group masks important differences between subgroups. This graph, again, shows asthma prevalence by Latino subgroup. And you can see that there's variety in the prevalences. And the confidence intervals are quite wide because as we divide the group of Hispanic Latinos into smaller and smaller subgroups, we have fewer survey responses. But in general, you can see that those of South American and Puerto Rican descent tend to have higher prevalence, and those from Central America and Mexico tend to have lower asthma prevalence. Differences are similarly seen when we subdivide the Asian group into subgroups. So in this graph, you can see that Californians of Filipino and Japanese descent tend to have higher asthma prevalence, and on the other end of the spectrum, those of Chinese and Korean descent tend to have lower asthma prevalence. When examining asthma prevalence by sexual orientation, we see that among males, gay males have higher lifetime asthma than straight males, and they also have higher current asthma than straight males. Bisexual males have intermediate prevalence that, because of these large confidence intervals, are not statistically different from either of the two other groups. In females, we see that lesbian and bisexual women both have higher lifetime asthma compared to straight women, and they also have higher current asthma prevalence compared to straight women. There are some factors that did not appear to be associated with asthma prevalence in our analysis. So using the most recent data from 2018 to 2019, we saw no association of lifetime or current asthma prevalence with household income level or urban versus rural residents. And I just want to quickly explain that in this analysis, household income was divided into two categories. Low income households were those that earned less than 200% of the poverty threshold of the United States Census Bureau's poverty threshold. And higher income households were those that earned more than 200% or more of the poverty threshold. And the dollar amount of this threshold depends on both the number of people in the household as well as their ages. And to give you a sense of dollar amount, for a hypothetical family of 4, so 2 adults and 2 children under the age of 18, in the year 2020, the poverty threshold was roughly $26,300. So for this family of 4, 100% of the poverty threshold is that value, $26,300. So 200% of the poverty threshold would be twice that amount, or $52,600. So in this analysis, that hypothetical family of four, if they earned less than $52,600, they would be considered low income. Next, we'll move on to work and school days missed due to asthma. Asthma symptoms and episodes can make it difficult for people to carry out their normal activities, leading to absence from work or from school or daycare. And in this analysis, school and daycare are combined. Among working age adults 18 to 69 years with current asthma, 11.6%, or roughly 280,000 Californians, were unable to work in the past year. These individuals missed an average of 1.2 days per year for a total of 2.9 million workdays missed. And in our analysis, we saw no association between missing work due to asthma and household income level. Among children 0 to 17 years with current asthma, 32.3%, or 230,000 children, were unable to attend school or daycare in the past year because of their asthma symptoms. Children missed on average 2 days per year for a total of 1.4 million days missed. And in our analysis, we see that low household income may increase the likelihood of missing school or daycare due to asthma. So again, our households were divided into two categories: low income, those earning less than 200% of the poverty threshold, and higher income, those earning 200% or more. And among children with current asthma, those from low income households, 40% of those missed 1 or more days, compared to 27% of children from higher income households. However, because of small survey sample sizes, the confidence intervals are quite wide, and so this difference is not statistically significant. The National Asthma Management Guidelines include strategies and tools to help people achieve and maintain control of their asthma. National guidelines recommend that patients with persistent asthma use a daily medication to control their asthma. Among those with current asthma, 50.4% of children and 44.7% of adults reported that they take a daily controller medication. National guidelines also recommend that all people with asthma develop an asthma action plan with their healthcare provider. Among those with current asthma, 70.2% of children and 72.3% of adults reported that they had developed an asthma action plan with their provider. In most cases, people who receive appropriate healthcare and manage their asthma well should not have to go to the emergency department or ED. Nonetheless, many people do seek treatment at the ED for their asthma symptoms. This graph shows age-adjusted rates of asthma ED visits in the US and in California and the US over time. So on the vertical axis, we have the rate per 10,000 residents. And then on the horizontal axis, we have year. And California data are shown in blue, and US data are shown in orange. In 2019, there were over 165,000 asthma ED visits, translating to a rate of 42.6 visits per 10,000 residents. And this rate has stayed relatively steady over since 2005. But you'll see a break at 2015, and this corresponds to the shift in asthma diagnosis from using ICD-9 coding to ICD-10 coding. So we recommend that data collected prior to the shift and after this change not be directly compared. Age-adjusted asthma ED visit rates for the United States are available only through 2009. But from the period 2005 to 2009, we can see that rates are quite a bit higher in the US compared to California. The average over this period is about 60% higher. I'm sorry, it's actually 30 to 50% higher. This graph shows asthma ED visit rates on the vertical axis by age group on the horizontal axis. And asthma ED visit rates are highest among the youngest children, and then they decrease steadily with age. This graph shows, again, asthma ED visit rates by age group, but now within each age group, the data are broken down by race ethnicity. And so you can see that within each age group, there are large disparities by race ethnicity. And of note, Black Californians, which are shown in the green bars, have the highest rates of asthma ED visits in every age group except for the oldest age group. Now we're going to look more closely and compare rates in Black Californians to those in white Californians. So Black Californians, again, are shown in green, and white Californians are shown in red. And within each age group, this bold number describes the disparity between the rates in Black and white Californians within that age group. So for children 0 to 4 years, we see that the rate in Black Californians, Black children, is 5 times higher than that in white children. Or put another way, Black children 0 to 4 years old are 5 times more likely to visit the ED for asthma compared to white children of the same age. So we can see that across every age group, Black Californians are 3 to 6 times more likely to visit the ED than their white counterparts. This graph shows rates for Native Hawaiian Pacific Islander Californians in orange. And we see that when compared to white Californians, Native Hawaiian Pacific Islander Californians are 3 to 9 times more likely to visit the ED for asthma. In this slide, Hispanic Latino Californians are represented by the blue bars. And we can see that the rates in Hispanic Latino Californians are just slightly higher than those of white Californians, about 1.1 to 2 times higher. And these yellow bars on the slide show data for American Indian, Alaskan Native Californians. And the rates, asthma ED rates for this group appear to be very similar to those for white Californians. However, a large caveat is that these data do not include visits to Indian Health Service facilities, which are run by the federal government and not the state. So there's the potential for undercounting if large numbers of people are visiting Indian Health Service facilities. And lastly, for Californians of Asian descent, asthma ED visit rates are actually lower than those of white Californians, except in this oldest age group. Low income does appear to have an effect on asthma ED visits. So in this graph, on the vertical axis, we have the percentage of Californians with current asthma reporting a visit to the ED within the past year. And then the respondents are categorized into coming from low income households versus higher income households using the same criteria as I described before. And those from low income households are 2.5 times more likely to have visited the ED for asthma in the past year than those from higher income households. This table shows the California counties with the highest asthma ED visit rates in children 0 to 17 years among those counties that reported at least 50 ED visits in children. And rank is shown in the first column. The number of ED visits is shown in the third column, and the age-adjusted rate of ED visits is shown in the fourth column. And notably, 4 of the counties in this top 10 list are located in the Central Valley. So we have Merced, Madera, Fresno, and King. And the Central Valley, for those of you who may not be familiar, is a largely agricultural rural region with a very large Latino Hispanic population. Other counties in this top 10 list include Imperial down here by the California-Mexico border, as well as Lake, Solano, Contra Costa, and Calaveras counties in Northern California, and San Benito in Central California. In terms of who pays for asthma ED visits, over 2/3 of ED visits are paid for by large federal and state programs. So 55% of visits are paid for by Medi-Cal and 11% paid for by Medicare. Private insurance pays for 25%, and the remaining 8% is covered by other sources such as workers' compensation or self-payment. Next, we'll move on to asthma-related hospitalizations. Being hospitalized for asthma is very serious and very costly, but asthma hospitalizations, like ED visits, are largely preventable through appropriate asthma management. This graph shows asthma hospitalization rates in California and the US over time, with rates on the vertical axis and year on the horizontal axis. And as before, California data are represented by the blue line and US data are represented by the orange line. In 2019, there were over 17,500 asthma hospitalizations, translating to a rate of 4.5 per 10,000 residents. Age-adjusted asthma hospitalization rates for the US are only available through 2009, but we can see that from 1995 to 2009, rates in the US were higher than those in California, and they were on average 60% higher. Like with ED visits, children experience the highest rates of asthma hospitalization. So here we have hospitalization rates on the vertical axis and age group on the horizontal axis. And you can see that it's much higher in this youngest 0 to 4 age group. And in fact, children under the age of 5 are 2 to 3 times more likely to visit the hospital for asthma than any other age group. This graph shows asthma hospitalizations broken down by both age and race ethnicity. And again, we see stark racial disparities in asthma hospitalization rates across every age group, particularly among Black Californians and Native Hawaiian Pacific Islander Californians. Across all age groups, Black Californians are 3 to 5 times more likely to be hospitalized for asthma than white Californians. Native Hawaiian Pacific Islander Californians are 3 to 9 times more likely to be hospitalized for asthma. Hispanic Latino Californians are 1 to 1.8 times more likely. So just their rates are just slightly higher than those of white Californians. Hospitalization rates are not available for American Indian, Alaskan Native children because the numbers are so low. But for adults, the rates appear to be just slightly higher than those of white Californians. However, again, the caveat is that these data do not include Indian Health Service facilities, so there is the potential for undercounting among American Indian, Alaskan Natives. And for Asian Californians, hospitalization rates are very similar to those of white Californians. This table shows California counties with the highest asthma hospitalization rates in children 0 to 17 years among those counties that reported at least 20 asthma hospitalizations in children. And again, the number of hospitalizations is shown in the 3rd column, and the age-adjusted rate of asthma hospitalizations is shown in the 4th column. And like with ED visits, the Central Valley really stands out when looking at hospitalization rates. So there are 5 counties in the top 10 located in the Central Valley: Sacramento, San Joaquin, Stanislaus, Fresno, and Tulare. And in Northern California, other counties include Butte, Lake, and San Francisco. And then in Southern California, we see Imperial and Los Angeles also on this list. This table shows the average length of hospital stays for asthma hospitalizations, average charges per hospitalization, and average charges per day, broken down by age groups. And you can see that for all 3 variables, the values increase with age. When looking across all age groups, the average length of an asthma hospitalization in California is 2.5 days, and the average charges per hospitalization are nearly $44,000. And across the entire state, the cost of asthma hospitalizations totals $770 million per year. Nearly 3/4 of asthma hospitalizations in California are paid for by either Medi-Cal or Medicare, 53% by Medi-Cal, and 18% by Medicare. Private insurance pays for 5%, and the remaining 24% is covered by other sources such as workers' compensation and self-payment. Now we'll discuss asthma-related deaths. This graph shows age-adjusted rates of asthma deaths in California and the US, and rates are on the vertical axis and years on the horizontal axis, and California data are shown in blue and US data are shown in orange. And in 2019, the most recent year for which we have data, there were 377 asthma deaths in California for a rate of 8.5 deaths per 1 million residents. And when we age-adjusted asthma death rates for the US are available only through 2009. And we look for the 10-year period from 2000 to 2009, we can see that the rates in California and the US are comparable. The rates in the US are either very similar or slightly lower than those in California. This graph shows asthma death rates on the vertical axis by age group on the horizontal axis, and data are not available for children in this very young age group because there are so few deaths. But we can see that asthma death rates increase with age, and the vast majority of deaths are in this oldest age group. This graph shows asthma deaths by race ethnicity, again with rate on the vertical axis and different racial ethnic groups listed on the horizontal axis. And data are not available for Native Hawaiian Pacific Islanders or American Indian Alaska Natives because of small numbers. And even though asthma deaths are uncommon, we can see that the Black Californians have the highest rate of any racial ethnic group, about 3 times higher than those of white Californians. And for the remaining groups that we're able to analyze, Hispanic, Latinos, Asians, and those identifying as multiracial, the death rates are similar to those of white Californians. This table shows California counties with the highest asthma death rates. And the number of deaths is shown in the 3rd column, and the age-adjusted rate of asthma deaths is shown in the 4th column. And again, when we look at the Central Valley, we see several of these top 10 counties, 6 of them: Sacramento, San Joaquin, Stanislaus, Merced, Fresno, and Tulare. And also in this top 10 list, we see Solano and Alameda counties, and those are notable because they contain the largest and 2nd largest percentages of Black residents in the state. And also on this list are Sonoma and Contra Costa County. you can imagine, because asthma affects so many people, that the costs due to asthma in California are enormous. This table shows annual costs associated with asthma in California, including direct costs, which are typically associated with medical care. For example, doctor's visits, hospitalizations, prescription medications. As this table also shows indirect costs, which stem from lost productivity due to missed work days, missed school days, and premature deaths. So looking at all these different costs, when we add them all up, asthma is expected to cost the state of California $13.3 billion per year. So it's clear when we look at surveillance data that asthma presents a huge public health challenge in California. We see from these data that poorly controlled asthma can prevent people from carrying out their daily activities, leading to missed school and work, potentially asthma ED visits or hospitalizations, or in the most severe cases, even death. Asthma inequities are differences in asthma prevalence, morbidity, healthcare utilization, and death rates across different groups that are widespread, avoidable, unfair, and unjust. Like many chronic diseases, asthma is heavily influenced by social determinants of health, the conditions in which people live, work, and play. Causes of asthma inequities include systemic factors such as racism, classism, and discriminatory policies that disadvantage certain groups. And asthma can be made worse by environmental factors such as indoor and outdoor air pollution. More specifically, in looking at racial discrimination and poverty, these two factors can really limit people's access to healthy and affordable housing. Housing insecurity and substandard living conditions contribute to chronic stress, as well as increase people's exposure to pests and mold, and all of those can serve as asthma triggers. We know that consistent preventive health visits are important to monitor and control asthma, but residents of low-income communities of color often face barriers such as lack of providers or lack of health insurance, long wait times, low health literacy, and the absence of culturally and linguistically competent providers. In addition, when healthcare is available, people of color are often treated differently by healthcare providers and healthcare systems, leading to poor quality of care. And all these factors are interconnected, and they all contribute to the racial, ethnic inequities we see in asthma. When examining all ages combined, Black Californians have the most severe asthma outcomes of any racial ethnic group. When compared to white Californians, Black Californians are 5 times more likely to visit the ED, 4 times more likely to be hospitalized, and 3 times more likely to die from asthma. The inequities are even more stark when we look at specifically at children. Compared to white children, Black children are 2 times more likely to have asthma, but they're 6 times more likely to visit the ED and 5 times more likely to be hospitalized for asthma. Disparities are also evident in Native Hawaiian Pacific Islander Californians. They are 4 times more likely to visit the ED and 5 times more likely to be hospitalized compared to white Californians for asthma. And compared to white Californians, Hispanic, Latino Californians across all age groups are less likely to have asthma, but they're more likely to suffer from severe asthma. So they're 1.4 times more likely to visit the ED and 1.3 times more likely to be hospitalized. And that suggests that among Hispanics and Latinos with asthma, they're more likely to suffer from uncontrolled asthma compared to their white counterparts. Hispanic and Latino children are 2 times more likely to have asthma than white children, but are 2 times more likely to visit the ED and 1.4 times more likely to be hospitalized for asthma. So how can we translate these data into action? Well, a large part of our mission at California Breathing is to make these data accessible to the public so that you can include these data in your work in advocacy, outreach, program planning, or healthcare delivery. So most of the data that I've presented today are available on the California Breathing website. And this is a screenshot of the website, and I just want to draw your attention to a few resources. The first is the Asthma County Data Tool. And this is an interactive online data dashboard, and users can view information on asthma prevalence, ED visits, hospitalizations, and deaths statewide and also by county. And we're in the process of revamping the dashboard. It's still available online, but soon we hope to release a newer version that's more user-friendly and intuitive. If you scroll down on our website, you'll see this information. And all the data, the data sets behind the County Asthma Data Tool are available for download from the California Health and Human Services Open Data Portal. The race ethnicity data on inequities come from 3 asthma infographics that our team developed this year for Asthma Awareness Month. And those can be downloaded in PDF from our website. And lastly, if there are data that you need that are not available in any of these other resources, please feel free to contact us at California Breathing, and we can work on generating a custom data report. So with that, I will hand the microphone back over to Ashley, and we'll hear about how California Breathing uses these data in our program activities.
Great. Thank you so much, Jackie, for presenting those abundant asthma surveillance data. So knowing what we know from asthma surveillance, how does California Breathing apply this to our programmatic work? Well, we prioritize populations disproportionately affected by asthma. And in California, these are geographic areas with a high asthma burden, children, and racial ethnic groups with documented asthma disparities. And I'll describe these a little bit more in the following slides. So as the state asthma program, we apply a population-based approach to improving asthma. We focus our program efforts to high burden areas, which we define as census tracts in the 75th percentile or higher for asthma-related ED visits. You may be asking, why census tracts and not zip code or county? Well, census tracts are small geographic areas designed to include an average of about 4,000 people. Compared to counties, census tracts provide more localized information with less variability within each unit. And census tracts often serve as proxies for neighborhoods and are useful for planning public health interventions because they are associated with a rich set of demographic, economic, and health data. Census tracts also have stable boundaries compared to zip codes, and census tract boundaries remain constant for at least 10 years from one census to the next, whereas zip code boundaries can change frequently. So within high burden census tracts, California Breathing will focus on creating partnerships with asthma programs serving children. Our goal is to reduce the disproportionately high rates of asthma ED visits and hospitalizations among California's children that we saw earlier, or that Jackie explained earlier. These partnerships with asthma programs serving children will also expand the Centers for Disease Control and Prevention's goal of preventing 500,000 ED visits and hospitalizations due to asthma in children nationwide, also known as the Controlling Childhood Asthma and Reducing Emergencies Initiative, also known as CCARE. And lastly, within high burden census tracts, California Breathing will expand partnerships with organizations serving Black and Native Hawaiian Pacific Islander communities. One way we can do this is through the Asthma Management Academy, a program that trains community health workers with a 20-hour skill building workshop to provide asthma self-management education. Because of their strong community ties and trusted relationships, community health workers and other types of health educators are ideal members of the asthma care team to provide home visits for asthma education and trigger reduction. So through the asthma, California Breathing will train community health workers from Black and Native Hawaiian Pacific Islander communities with high rates of asthma ED visits. And lastly, California Breathing will also work to obtain asthma surveillance data from Indian Health Services to better understand the burden of asthma in American Indian and Alaskan Native communities. So with that, we know that we have presented a lot of information about asthma surveillance today, and we wanted to open it up to questions. So if you have a question, please type it in the chat. I'm going to go ahead and prompt Jackie with some of your questions. And I see some in the chat, so I will start from the beginning. Okay, Jackie, are you ready?
I am.
Perfect. So someone said, I would love to see the oncoming data showing the ER visit and hospitalizations during COVID 2020 to 2021. Can you estimate when these data might become available?
Yeah, so these data usually, so the way that the data collection process goes is that, so we'll have the entire year. So for example, 2020, December 31st, 2020, the year ends, and then OSHPD will take data for that entire year and they'll spend a lot of time cleaning it and making sure that they remove duplicates, that it's as complete as possible. And that process takes pretty much a year. And so we don't actually get the data from them until we won't get 2020 data until the end of 2021 or possibly even the beginning of 2022. And then it takes me usually a couple months to do the analysis and calculate all the rates and whatnot. So you can expect to see 2020 data probably by mid 2022. So there's about a year and a half lag, unfortunately. So for 2021, you'll see those data hopefully early to mid 2023.
Great, thank you. And can you remind us what OSHPD stands for?
Oh, OSHPD is the Office of Statewide Health Planning and Development. And they are the state agency that collects all ED visit and hospitalizations data from state licensed hospitals.
Great, thank you. Our next comment / question is staggering disparities. Are the ED visit rates or are the ED visit rate differences statistically significant?
So for survey data, because we're taking just a sample of the population and asking questions and then trying to infer back to the whole population, we have confidence intervals and we talk about whether things are statistically different or not. For ED visits and deaths and hospitalizations, we actually in an ideal world get information on every ED visit, every hospitalization, every death. So we don't actually have to calculate confidence intervals. And so we don't do that same type of kind of question of whether they're statistically different or not. Like there's no uncertainty with the estimate, if that makes sense. So we can just say that it's 5 times higher. Like it's Yeah, so there's no uncertainty in the estimate because we get all the data on every hospitalization, on every ED visit. Does that make sense?
Yeah, we'll make sure. I'll keep an eye on the chat to see if there are any follow-up questions. But that was great explanation. Okay, we have another question. Why is it that children's ER visits are higher?
That's a really great question. So, and Ashley or anybody else on the CB team, feel free to jump in. But kind of my understanding is that children, their airways are still developing. They're very small. It's very, if they start having any sort of respiratory problems, they can go into respiratory distress very, very quickly. And I'm sure as a parent of young children, it's extremely frightening if your child can't breathe. So you want to, get attention immediately, take them to the ED. Ashley, do you have any insight on this?
No, I was going to say the same thing. I mean, or not the same thing, but somewhat of the same thing. I mean, evidence suggests that children are just more sensitive or more vulnerable to allergens and other asthma triggers than adults. And so that makes their asthma control and their management the more challenging. So I think, yeah, just piggybacking on what you were saying.
And asthma is also very difficult to diagnose in very young children. So it may be, if they don't have, the diagnosis, then maybe getting them on medications might be more challenging. I'm not sure.
Of course, thank you. Okay, we have a lot of questions, so I'm going to keep going.
Okay, keep going.
Perfect. Brenda, I hope that answers your question. If not, please put it in the chat and we can circle back to it. Okay, our next question is, are there any studies why patients go straight to the ED instead of using urgent care services?
I personally am not aware of any studies specifically looking at this. I mean, that's a good question, and it's something I could look into and try to get back to folks. So maybe well, in a couple weeks, we can send out like a follow-up email to if there are any questions that we're not able to address today or any additional resources. So I can look into that. I will see if I can find some information on why patients go to the ED instead of urgent care. But I imagine that part of it is that these episodes may be occurring at times when urgent care is not open, and the ED is 24 hours.
And I'd like to jump in. Brenda put in the chat, might not have a PCP or insurance in the ERCs, everyone.
A very good point.
Yeah, great. Okay, our next question is there any data for Alameda County?
Yes, there are data for Alameda County. I did not show county-specific data in this webinar, but if you go to the county asthma data tool, you'll see asthma data. You'll be able to select any county, and you'll see much of the same data that I presented today, but on the county level.
Okay, our next question is, what is the population size of the lifetime and current asthma data set?
I'm sorry,
what is the population size of the lifetime and current asthma data set?
Do you mean how many people were surveyed? Or how many people have lifetime, estimated how many people have lifetime asthma and versus current asthma?
Why don't you go ahead and address both points that you just brought
up? Okay, so for lifetime asthma in California, so the most recent data we have are from 2019. And we tend to combine 2 years worth of the CHIS survey data just to get more reliable estimates. And so for 2019, it was estimated that 15% of Californians, or 6.2 million, had lifetime asthma, and 8.6%, or 3.5 million Californians, had current asthma. In terms of actually how many people answered the survey questions to get those estimates, off the top of my head, I don't have those answers, but I could find out. They are available from likely the CHIS website. So CHIS is run out of UCLA, the UCLA School of Public Health. And so if you look up the CHIS UCLA website, you can see all sorts of information on every cycle of the survey, including sample sizes and the number of, I think they would tell you the number of people who answer each question.
Great, thank you. And if anyone needs more of an explanation or clarification, please jump into the chat. We're happy to do that. Our next question is there any information that reports a reason why patients use ED instead of getting an appointment with a primary care provider first?
So I do, there are, I think, there is research on this. I can't quote any of it off the top of my head, but I think for many of the same reasons that have been brought up previously, a lot of people do not have primary care providers or health insurance, so they don't feel that they can go to a provider. There's also, I think, in California, there's a sizable population that may be undocumented, and the ED will serve everyone, regardless of citizenship, regardless of insurance. So I think that that ends up being a resource for a lot of people.
Great. And I want to thank Brenda and Marina for jumping in. I think Brenda's initial comment, which I brought up in the other ED question, was maybe an answer to this one: might not have a PCP or insurance. The ER sees everyone. And Marina also added from the chat a lack of understanding of the healthcare system. So thank you. Okay. Our next question: is there a study on the level of health literacy of the parents of the children with asthma?
That's a very good question. I actually am not sure, but this is definitely something that I can look into and send out an email with resources if we come across any. Ashley, are you aware of research on health literacy of parents with children with asthma?
I don't know of any specific studies, that that come to me in the moment, but I do know that there is evidence on the health literacy levels of community members, and that's something that we can definitely look into and make available. That's a really great question. Thank you so much for bringing that up. Okay, our next comment is, in Imperial County, we have air quality issues, but since the COVID situation and kids staying indoors and wearing masks, it seems that the ER visits are less. Thanks, Aide, for sharing that. And it looks like we've come to the end of our questions. Last call for any questions about the presentation around asthma surveillance and how we use asthma surveillance data to inform our programmatic actions in California breathing. We'll wait a couple seconds to see if there's any more questions in the chat, but please stick around. We're going to start our next, oh, I have one, just kidding. What was the name of the tool that is county specific to data?
It is the County Asthma Data Tool. It's very descriptive. And you can find a link to it from the California Breathing website under asthma data.
Great. And I also want to thank Jennifer Flattery for including for answering a question here. She says the other state asthma program serves people who get asthma related to their work. It is called the Work-Related Asthma Prevention Program. And you can find information about that program at cdph.ca.gov/WRAPP. Thanks, Jennifer, for adding that.
So the county asthma data tool, I don't know if someone else, Natalie, maybe might be able to put the URL in the chat for folks. Okay, so if there are no other burning questions at the moment, thank you, Natalie, for putting that in. So here is for folks who have not seen or been able to find the county asthma data tool. Here is the URL in the chat. So we would like to get some feedback from you, the participants. We are always looking for ways to improve our surveillance system and our data offerings. So we have a few questions that we would like to pose. And we've actually set up the first two questions as polls so we can capture your answers. So can we launch the first poll? So the first question is, do you use California Breathing's county asthma data tool? So have you ever used it in the past? Do you currently use it for your work? Okay, and then so I think we can probably go ahead and close the poll. So it looks like about 30%, 28% of folks responded that they do, which yay, we're very happy to hear. But over 70% responded that they don't. And so that's very useful information for us because at the moment, that is the primary way in which we are publishing our surveillance data. So I'm just curious, for those of you who responded that you do not use it, and you can just put this into the chat, what are the reasons? Have you never heard of it? Do you not like to visit websites for asthma data? I'm just curious. Okay, so you see, I didn't know it existed. Never heard of it. Okay. Well, I'm glad that I'm really glad that we are spreading the word on this resource. Okay, so it sounds like most people just weren't aware that it's there. So you have the URL in the chat, and so Genevieve says, "Don't know how to use it in my work," and so I'm not sure if that it means like you're not sure like how to incorporate asthma data like into your day-to-day work, or but if you mean like you're not sure how to like navigate the tool itself, I do want to mention that we recorded a webinar back in December 2018 when we launched the tool that gives an introduction to the dashboard and also kind of an overview on how to navigate the dashboard to get the data you're interested in. So in a follow-up email, we can also send a link to that recording if that's helpful to folks. Okay, so I think we can go ahead to the next. Oh, it is also good to know that, yeah, so there is a 2-year lag with data. So currently the most recent data, so for ED visits and hospitalizations, the most current data are 2019, because those are updated annually. For CHIS data, because we combine 2 years worth of data to get more robust estimates, especially for at the county level, The most recent data are 2018, 2019. But the CHIS data on asthma prevalence won't be updated. The next chunk of data will be 2020 or 2020, 2021. So those statistics probably won't be updated until 2023, which sounds like a really long ways out. And just as an FYI, the death data are analyzed in 3-year periods. So the most recent, I think right now, I'd have to double check if we have 2019 included. If not, the death data will be updated soon, within the next year or two. So our second question is, can we get the poll up? Oh, do I have to click? I'm not sure if I need to do something on my end.
Jackie, while we're waiting for our second poll question, can you remind everyone what CHIS is?
Oh, yes. CHIS is the California Health Interview Survey. So it's the statewide survey that it's done over the phone and online now, because apparently people don't like answering calls from unknown phone numbers. And so it surveys, the number of households changes from year to year, but currently it surveys about 20,000 California households, and it asks a variety of health-related questions, including questions on asthma. Leonie, do I need to do anything on my end? Oh, okay, yay, thank you. So our second poll question is, what are your preferred methods for accessing asthma surveillance data? And you can select more than one choice, so please choose all that apply. And just for clarification, so online interactive data dashboard would refer to something like our county asthma data tool. We also have downloadable data sets that are usually in Excel format. And also, if you select others, please put in the chat what other method you'd like. So it looks like we can probably close the poll. So 3/4 of you said that you like the interactive data dashboard. So that's great news for us. Downloadable data sets, about 35%. And we realize that, not everybody needs, all the entire data set. Like if you're just looking up a couple statistics for your particular county, whatnot, but we do get requests for the data sets, and so we want to make those freely available for download as well. It's nice to see that there's also a lot of interest in downloadable graphs, tables, and infographics. So currently, you are able, from the county asthma data tool, if you are interested in, say, Alameda County, and you select that county and the particular indicators and the year you want, you're able to display the graphs, and you're also able, if you scroll down to the bottom, I believe there's an option to to create a PDF of what you've created on screen. And then you can then print or download the PDF or print it or use it for your reports or presentations, anything you need. And then also the infographics that I presented, information from today, are available for download on our website as PDFs. This is interesting. Some 38% said written report. And this is something that California Breathing used to release written reports in printed format. And we have not done so in many years for various reasons. But it's good to know that folks are still interested in that. And so perhaps that is something that we can discuss again internally, and now that we know that there's an interest in it. And then I'm curious, for folks who put others, what other method would you like to see? How else would you like to see asthma surveillance data shared? Is anybody able to put that into the chat? No? Okay. Well, feel free if you at any time would like to let us know about additional methods that you think would be useful for sharing asthma data, to contact us at California Breathing. We're always happy to hear from you. And then our third question is that, given the asthma indicators you've seen us present today, are there additional ones that you would like either added to the online data dashboard, the county asthma data tool, or just that would be useful to your work, that you would like us to include in our analysis and our presentations? And you can enter that into the chat. So I don't see any responses yet. So I will just mention that we do hear that folks, data for Census Tracts. Okay, so I was actually going to address zip codes and Census Tracts. So data for Census Tracts. So Ashley gave a very nice explanation of why Census Tracts are so useful in for public health. And so I will start off by saying that ED visits by Census Tract are available. These data are available through Cal Enviro Screen. I'll type that into the chat here. Cal Enviro.
Right up by the 210 freeway. Otherwise, it would be the Chino.
So ED visit rates by Census Tract are available in Cal Enviro Screen. We don't produce that data because the data set for ED visits that we receive, it's de-identified. It has no patient. We get the county of residence and the zip code of residence, but we don't get an address. So we're not able to actually assign patients to Census Tract. And the way that Cal Enviro Screen is able to produce the data is that they actually do take the zip code data, and then they do some statistical modeling to kind of estimate, create Census Tract level estimates. So that is a great resource. I highly recommend visiting their site and using those data. But we at California Breathing are not able to produce Census Tract estimates. I will say that a lot of people also ask for data by zip code level. And in general, so we do publish ED visit rates by zip code. And that data set is available on the Open Data portal. If you search for asthma in the data sets, you'll see it. And also, I want to mention that Tracking California, also has a interactive kind of data website, and one of their indicators, they do include asthma ED visits by zip code. So that data are available to view on the Tracking California website, and also for download from the Open Data portal. And if you need additional information by zip code, for example, hospitalizations, that you can always contact us at California Breathing, and we can try to calculate those numbers for you. Let's see. I just want to make sure I'm not missing. So maybe uninsured patients, to figure out who's using the ED. So I did. So in the webinar, I did present, so among all the ED visits, the proportion that are paid for by the various different sources. And then so this is tricky because we don't get information on insurance status per se. So in our data set for hospitalizations and ED visits, we don't get the patients, whether or not they have insurance and what kind of insurance they have. All we get is who is billed for the visit. And so that's how we get the data for, Medi-Cal pays for 53% of asthma hospitalizations, that information. But yeah, so that's not specifically about like who's uninsured though. In terms of like looking at the uninsured population, I feel like, you'd almost have to do like a survey to get that information, because yeah, we don't get insurance status on the patients themselves. But that is something that I could look into in terms of, getting more information on the uninsured population. So Brenda says, I was wondering if there are any recommendations for air purifiers that remove the most particulates. Ashley, are you aware of any recommendations?
Yeah, I'm going to go ahead and put a link in the chat to the California Air Resources Board. They have a list of certified air cleaning devices. And they say since 2010, all portable indoor air cleaning devices sold to people or businesses in California are required to be certified by CARB, the California Air Resources Board. So I put that link in the chat, and they also have other resources and help how to select a safe and effective air cleaner. I also see that Justine Weinberg has also put in some air cleaner guidance. It looks like she's linked to something from a document from the San Francisco Department of Public Health. So that's also in the chat as a resource. Thank you. Yeah.
So Laura Lee says, curious if you know of any resources pertaining to ED visits, hospitalizations, and wildfire areas. So I know that there was a research paper that came out a few years ago looking at asthma ED visits at the time of the San Diego wildfires. And I could definitely send that out as a resource, but in terms of so I'm not sure if you're talking about like research studies linking wildfires to potentially increased ED visits or asthma ED visits or hospitalizations, or yeah, I'm not sure.
Yeah, Laura Lee, I'm with the Lung Association here
Hi.
in California and San Diego. Thank you for that great presentation. A lot of our education work recently has been wildfire education and the implications of that on respiratory health. And the studies from, that I have seen with asthma exacerbations and ED visits, a lot of it is a little bit older or just for a particular county. So I was just curious if anything's been looked at a state level as we continue to get these very, tremendous wildfires, what the broader link, the higher, level look at asthma and how it's being impacted by wildfires.
Yeah, this obviously is a very, very important and very timely topic. So there is a group at CDPH that's currently, they have an ongoing study looking at different health impacts, including asthma, from wildfires. And they, I think, are preparing their data for publication, but they're not quite there yet. So I think in the hopefully coming year or so, you'll see a lot more studies on linking, wildfires to different health conditions and, potentially exacerbations for conditions including asthma. Ashley, do you remember kind of the scope, more about the scope of their study or their timeline for publication?
No, but I was going to say, I think that we're talking to them very soon, so we can let everyone on the California Breathing listserv know of when they're going to make those data and those findings available. And just a plug for our listserv, if you are not currently receiving our California Breathing emails, please put your email in the chat or reach out to us after the webinar. Jackie and I will put our email addresses and the California Breathing address here momentarily. Please reach out to us so that we can add you immediately so that you can stay up to date with all of our asthma information and resources that we send out.
Okay, so sorry.
Go ahead. On that note, I just wanted to ask just quickly, are there any other questions or comments before we transition to ending our webinar? And I just put that in the chat just as a last call. Sorry, Jackie, go ahead.
I was going to say pretty much the same thing. It looks like we don't have any more questions. If you do have questions, please feel free to contact us. But we would like to leave a little bit of time for the evaluation. So again, here's our contact information. You can always reach out at California Breathing, or you can email us individually. Here's our information. And before you, or as you sign off of the webinar, you'll be taken to a very short evaluation. Please fill it out. This information helps us improve our program and our webinars. And as a reminder, our next webinar is scheduled for October 19th, and it will be on the Asthma Management Academy and its evaluation. The registration link is listed on this slide. And the link is open, I believe, or it's live, so you can go ahead and register if you have not already. With that, thank you very much for joining us, and we appreciate all of your feedback. Thank you
So much, everyone. So wonderful to see you all.